Greetings, aspiring surgery trainees. Welcome back to our open cholecystectomy series, where we delve deeper into the intricacies of this essential surgical procedure. In this third installment, we are thrilled to present an exceptional surgical demonstration that focuses on a cutting-edge technique, that is stapler-assisted dismantling of cholecystic-duodenal fistula. So friends, hopefully you have already watched our previous two videos in this series. If not, do watch them before joining us here, in which we have already discussed four cases of open cholecystectomy of different scenarios, and one case was lab converted to open chole for a residual GB stump. Please check the description or visit the channel homepage for details. Along with cholecystic-duodenal fistula, we will also demonstrate step-by-step guide how to tackle this difficult case, which was shrunken gallbladder with the flush opening into the CBD along with choledocholithiasis. So in this video, we will demonstrate basically open cholecystectomy, that will be retrograde antegrade combination, dismantling of the cholecystic-duodenal fistula, and how to localize the CBD. Choledocholithiasis and choledochodynostomy we have not showcased in this video because it was not basically ideal for demonstration purpose because of the dense adhesion, that we will demonstrate in some other case. So our dedicated team of surgical mentors will take you through the entire process, sharing their extensive knowledge, the tricks of trade, the best practices, and invaluable tips. As a surgery trainee, this video offers an excellent opportunity to enhance your skill set, enabling you to develop the confidence and proficiency required in mastering this intricate procedure. So friend, I am repeating one of my often said line, that is, you may create a bridge between basically earth and moon with the help of laparoscopy, but as a surgeon, as a GI surgeon or a general surgeon, you cannot bypass the open cholecystectomy. This is one technique, one procedure that everybody has to master and know it all. This was a case of 67-year-old female with no known comorbidities, with no prior history of any surgery. She had a history of pain abdomen for last 4 months, which was related to back. There was assured history of fever with chills, intermittent episodes, for which she took medication from the local hospitals, and there was an undocumented weight loss, assured loss of appetite, but there was no history of jaundice. Her general physical examination and abdominal examination was unremarkable. Except for the raised postprandial blood sugar level, the rest of the investigation were normal, and as I said, she was not a known diabetic. So before coming to us, she had already underwent a CT scan abdomen, which revealed contracted gallbladder, which was measuring 3.3 into 1.9 centimeter, with choledocholithiasis, with bilobar intrahepatic biliary reticle dilatation, and suspicious cholecystic-duodenal fistula. CVD was dilated, measuring 16 mm. With pneumobilia, that is air in the bile duct, was present. So the MRCP was repeated at our center, which revealed dilated CBD with bilobar IHBRD. CBD was measuring 18 mm in proximal part, and distally it was getting narrowed down with presence of choledocholithiasis, with suspicious communication with D2, that is cholecystic enteric fistula, and with pneumobilia. So these are the MRCP images, and we have already discussed different types of MRI MRCP findings in our previous videos, so do check them out. So there was a bilobar IHBRD as highlighted, with the presence of void in the CBD, there was a choledocholithiasis with suspicious cholecysto-duodenal fistula. So here friends, this you can see this white streak. So any white basically structure or white this outline is indicative of fluid. So there was a communication with the gallbladder fundus as highlighted here, and because this is difficult to make out whether it is a cholecysto-duodenal or cholecystocolic fistula, because the hepatic flexure of the colon also comes here only as a cholecysto-duodenal fistula, but we had a suspicion in mind that it can be a cholecystohepatic fistula also, And friends, as you must have seen this presentation, so this lady with the 67-year-old age, suspicious history of weight loss and loss of appetite, so then you have to keep in mind the possibility of CA also. So that the differential diagnosis for us was also, we kept the possibility of CAGB also in this case. Different basically cuts. And so as I said, MRI findings we have already discussed in detail in our previous talks, so I'll not go through the details. Some of these cuts are close-up view for better demonstration, and we will also record a video dedicated to the MRI or basically imaging anatomy of the biliary tree, and that will be helpful for you guys. So in the axial images, you can make out there's a bile over IHBRD. With pneumonia, air is seen as black in these T2 patent images. Why T2? Just remember that H2O, T2. So any fluid or watery structure will be white. So that is a T2 images, and air is seen as black. This patient was planned for exploratory laparotomy with open cholecystectomy, with dismantling of the cholecystic-duodenal fistula and choledocholithiasis after choledocholithiasis, with the backup plan of Roux-en-Y hepatocholinostomy. Of course, we have to rule out the malignancy first after doing exploratory laparotomy in this case. So our intended incision was exploratory laparotomy followed by right modified Makuchi incision. About the different type of exploratory laparotomy, we have a dedicated series available. So do check that out, in which we have covered Chevron, Makuchi, midline laparotomy, etc. Embrace the challenge of open cholecystectomy. Each incision is a step toward mastery, and every stitch brings you closer to the art of healing. Don't forget to like, share and subscribe to our channel, and hit that bell icon for all the future updates. And do support us, help us to reach more eager minds hungry for knowledge. So and we extend our heartfelt gratitude to each one of you, especially the channel members, for joining us on this surgical journey. Your interest and support inspire us to create valuable educational content for aspiring surgeons like you. So until next time friends, stay curious, stay passionate and never stop learning. Thank you very much. Happy learning.